Good day to you. I'm Dr. Lalith Mendis from Sri Lanka. I want to bring to you a scientific discussion on the validity of the PCR test, polymerase chain reaction using reverse transcriptase. So I'm looking at slide number 6 in my presentation. A very brief discussion on the polymerase chain reaction. What is being done is that those people who have been exposed to the COVID-19 virus, of course this could have been used for any other RNA virus and it has been used, but in the present context of COVID-19, what was known as SARS-CoV-2 virus, RNA sequence, which is a gene sequence that is specific for the virus, can be detected in those who have been exposed to the virus. So this little piece of the RNA sequence, the gene sequence, can be detected, and usually what they try to do is detect a sequence for S protein plus N protein, or for E protein. They decide on a gene sequence. Now the gene sequence should not be too short. The probe must not be too short, because if you make it too short, false positives can come. Now all know that PCR is highly specific, very sensitive, but some don't know that its very sensitivity, its highly sensitive nature creates problems. So PCR can have certain kinds of false positive interpretation. This is the important thing, because PCR, polymerase, detecting that RNA piece, what happens is you use reverse transcriptase and translate or convert the RNA piece of virus into a piece of DNA. So it's a DNA that gets recognized. What happens is, any time that you are exposed to the virus, that RNA may be remaining in you. So here, look at this graph. In slide number 6 in my presentation, you will see a blue bell curve where probably the person was infected and infectious with CoV-2, which means, to say infectious, you have to have the clinical features of COVID infection. Now there is a problem with clinical features of COVID infection, because there may be other respiratory infections with cough and with pneumonia. There's no way that you can do a CAT scan, chest X-ray or MRI and know for certain this is COVID lung. To know for certain it is COVID lung, you have to do either a histopathology, which is not possible at that time, or you have another way of doing it by checking upon the cytokine molecules involved in the cytokine storm, pathognomonic of COVID, and of course the HIV lung pathology, when it is having a cytokine storm, is also like the COVID lung. This is why Professor Luc Montagner is on record saying this COVID-19 virus seems to be a former virus, for instance taken from the bat coronavirus, and at a furin point of genetic engineering, furin is an enzyme used for genetic modulation, a piece of the HIV sequence has been put there to make the S protein, the spike protein, penetrate particularly the lung tissue by attaching itself to ACE2 receptor. So the debate is current. Now we are looking at the PCR consequences, the consequences of doing PCR testing, which was an epidemiological test to find the prevalence of a RNA virus presence, or for that matter even DNA, finding a virus presence in society, the prevalence, PCR was used. Now it has been converted into a diagnostic tool or diagnostic test, which was not the intention of its founder. Now, for PCR test to have any validity in diagnosis, firstly, it must have a clinical history, clinical signs and features of COVID infection. So if a person having COVID infection has a PCR plus, then you can say it's probably the COVID-19 virus. Now, other problem with saying PCR plus is, this is not a direct test. The presence of a little DNA material is subjected to cyclic amplification. So you have the CT value, which is the cycle threshold value. So at 32, if it's reasonable, at 32 where the linear amplification stops and after that it becomes exponential amplification, at 32 CT or cycle threshold, if it is positive, it's probably positive. But by the time you are passing the 32nd cycle threshold, many other things may look positive and the result is not reliable. Anyway, the result is not reliable. PCR positive does not mean infected or infectious unless the person has clinical features. Then by extension, if close contacts have PCR positive, it is a reasonable assumption, still it is assumption that this close contact had RNA particles and became PCR positive from the relative who now has COVID symptoms. So the first contact with PCR positive, isolating that person, quarantining that person, and even giving that person hydroxychloroquine, vitamin D and zinc, and if that person is immunocompromised and likely to have a cytokine storm, adding to that low dose aspirin and omeprazole is reasonably scientific, though it's still an assumption, because though that person though the husband had COVID positive and COVID infection, if the wife has PCR positive, it doesn't necessarily mean she got it from the husband now. She could have got it from the husband before that. Now, we have had test cases where the wife died being PCR positive with COVID lung symptoms, but in this case in Sri Lanka in the first wave, husband was a baker, but husband did not have PCR positive. So therefore, again and again the issue arises, what does the PCR positive mean? Again, let me reiterate this. So if a person has COVID clinical features and the PCR is positive, it is reasonable to say PCR, this is COVID infection. But bearing in mind, many other infections may have lung symptoms of cough and pneumonia without that being COVID. But if there's the microthrombosis of the COVID phenomenon, which can be verified, then very definitely you can say the present person having COVID lung pathology, COVID lung immunopathology, and is now having COVID clinical features and having PCR positive is probably COVID infection. And if the person that is infected by him, his wife, let's say, becomes PCR positive and develops symptoms, recent symptoms, then also it is reasonably certain it is COVID infection, COVID-19. But if wife has a PCR positive but does not develop clinical features, it's only her contact history, and then that RNA piece she might have got it from elsewhere in a previous episode. We have to consider that. Now that is stage 2. Now let's get to stage 3. When PCR is done at random, roadside in any given population, track and trace system that is applied in some countries, someone shows up with PCR positive, no contact history, no clinical history. What does it mean? It means some time back he was exposed and he has now developed immunity, no clinical features, no disease, and now taking a whole horde of them for quarantine procedure is completely unscientific. Now this is not clarified, so nations and governments are in uproar and confusion. If you are launching a pandemic, just hear me through, if you are launching a pandemic, you have to instill fear by saying Anybody PCR positive is infected, or it's a case, disease. All three applications are wrong. If person is on a random sampling test, if the RNA shows up on a PCR cyclic amplification, categorically the government and the technical committee must come to a conclusion that cyclic amplification will be done only up to 32 cycles thresholds. Anything after that would be artifact, not accepted. But I am going to show you 6 other ways in which a false positive can happen. Because everybody keeps saying PCR is very specific for COVID-19, but that very specificity comes out of many times of cyclic threshold amplification. That has its own problem, which is not described. I repeat, so if a random test shows PCR positive, it only means that person was exposed to the RNA piece some time ago. It does not mean disease. He should not be quarantined. That area should not be shut down. So when a country has had a first exposure, we will come to that now, see the behavior of the PCR testing. Now this is one test case. The blue bell, the bell curve is where the person might have had the viral particle and was virus positive. And the problem is that many, now hear it again, PCR positive, if you try to inoculate a cell culture, you can't isolate the virus. And there have not been enough standardization and models being done where where people have infected cell cultures in the lab with a PCR positive person's material. That is not happening. So the PCR positive remains in abeyance without the important clarification, confirmation of virus isolation in a lab cell culture. You have to bear that in mind. PCR positive does not mean live virus. It only means a piece of RNA. So in this diagram that you are seeing, the graph can be seen, isn't it? Diagram you are seeing, bell curve is where the live virus might have been, and the green curve is where the virus, where the PCR may be positive, and it means that person is not infectious. It doesn't mean infected either. It only means many months after the episode, RNA remains in the population and it can be detected in a PCR testing. Now we go to the next slide. Next slide, slide number 7 you see is from Spain, how Spain PCR behaved. Now the first green bump was the first episode when people became infected and PCR positive, and then the second one is when PCR testing was done again. Now the PCR testing, many people in the population were PCR positive. But you can see the brown bump, the brown one is the first brown bump correlates the first PCR positive episodes correlate with the death rate. The brown ones are the death rate. When you kept on doing PCR later, though the PCR went up, death rates didn't go up, which means that PCR is depicting immunity to the virus. RNA piece is there. That is not infected, that is not infectious, because there is no correlating death spike. Now in England, this is where the prediction went wrong. In the UK, they predicted a big spike and so many deaths in the second wave. So many deaths didn't come, but the lockdown was done because of unadvised counsel, wrong counsel, unscientific counsel to the Prime Minister. Now we come to the third curve. Here it is, the black curve shows PCR positives and blue curve shows, blue graph shows the deaths. You can see with the first episode, people were PCR positive, many, and then deaths arose. But as the disease wore out, the virus went on in the society, PCRs increased again when the PCR testing was done. This was not infection going around, but this is PCR testing going around and detecting the RNA virus piece now in a greater number of people in the population. Test increased, PCR positive increased, that does not mean infection increased. You have to understand this. How do you know that? Deaths didn't increase. So you can clearly see there is a dissonance that is not being explained, such as though the PCR testing and numbers increase, it is not clinical disease, it is not even contact history. You must understand this. Now we come again to some other things. So PCR positive for COVID, now my slide number 3, PCR positive for COVID-19 does not mean infection, infectious or infected. It only means a fragment of RNA was found. Clinical history is the most important thing. Secondly, an immediate contact history. So that means from that case, that person should have been infected, at close quarters. So this is not about one person is infected in a block of apartments and in some corner of that flat there's another person with PCR pus and he's also lumped in the cluster. This is not science. This is actually non-science. I'll repeat it. When one person is infected, let's say level number 1 person is infected, then you are doing the whole cluster, so to say, and on level number 10 of the building, another person has PCR plus. It does not mean even a contact history because it's too far. It's too far. It probably means in a previous episode that person got immunity with the RNA piece being still there. Yes. Now we come to next one. Our impression is that most data for all countries is in, let me finish with slide number 3. Here is an explanation. Vaccine also attempts to deliver COVID gene RNA sequence via nanomolecular technology in order to produce the spike protein S and N protein, which will make the body to make antibodies and T cells against the S protein and N protein, and the person is hopefully ready. So when a person has a PCR positive and no symptoms, now what is the case of a person who will receive the vaccine with the RNA? He will also have a PCR positive. So when a person has PCR positive and no symptoms, it means he has immunity. It is wrong to use the term infected. If you do PCR on person who gets the vaccine, he will also be PCR positive, which means COVID RNA has been found. It is not infected, it is not infectious. Now slide number 4. Our impression is that most data for all countries is in agreement with our interpretation, namely PCR positives do not correlate to deaths in the future and are therefore meaningless on their own to interpret the spread of the virus in terms of potential deaths. Slide number 5. PCR true positive versus infectivity and virulence. Does a PCR positive mean true positive if the gene fragments targeted in the PCR are unique to the virus and the PCR is very robust? There is speculation as to whether the PCR can indeed find the virus from a person's sample, or maybe the PCR is not specific enough and might give positive when other viruses are present. Some PCR manufacturers tell us there is cross-contamination and non-specific interference with a list of viruses and others in their instruction manual. So you have to know that. I have given the citation there. So some manufacturers agree that there could be some contamination. Possibility 1, the PCR test is positive, but this was due to cross-contamination or non-specific interaction. Then the test would be a false positive because the SARS-CoV-2 virus is not present in the sample. This means the PCR positive is a false positive rather than a true positive. But this is not the only possibility we want to focus. So you should refer to the whole article in the Center for Evidence-Based Medicine, CEBM is a Norwegian website. CEBM, excellent website for you to refer to. Now I go to slide number 9. Need to know if short probes are amplified over 40 times. That would be unscientific. Because of rightful concern regarding disease transmission from asymptomatic and pre-symptomatic cases, this advice is not being followed. As a result, the great abundance of testing is screening, not diagnostic. One way to reduce false positive result is to repeat the test using a test with a different format, different manufacturer. Due to limited testing facilities, confirmation is not routinely performed, and only a few positives are confirmed by a second RRT plus PCR assay. I conclude it is likely that at current active disease prevalence, the positive RRT PCR results of many asymptomatic persons are false positive. Yes, I have given you the citation there. If you need this whole PowerPoint presentation, please give me a WhatsApp call, or not WhatsApp call, send a WhatsApp message to +94 77 49 59 214. This is a little tedious, but if you are a medical personnel, you must know this. If you are an infected person, you must know this. Even if you are a teacher, you must know this. And since fake science is appealing to the public directly, you better know true science to defend yourself against fake information. False positive. The high false discovery rate that results when prevalence is low from false positive rates typical of RT-PCR assays of RNA viruses raises the question about the usefulness of mass testing and indicates that across a broad range of likely prevalences, positive test results are more likely to be wrong than are negative results, contrary to public health advice about SARS-CoV testing. There are myriad clinical and case management implications. Failure to appreciate the potential frequency of false positives and the consequent unreliability of positive test results across a range of scenarios could unnecessarily remove critical care workers from service. 11. Expose uninfected individuals to greater risk of infection because of unnecessary lockdown and quarantine. Delay or impede appropriate medical treatment for needed medical therapies, lead to inappropriate treatment, degrade patient care, waste personal protective equipment, waste human resources in unnecessary contact tracing, hinder the development of clinical improvement, and weaken clinical trials. Measures to raise awareness of false positives, reduce their frequency, and mitigate their effects should be considered. This article on ResearchGate. My slide has the reference. Now, what causes false positives? Slide number 12. 1. Cross reactions with other genetic material. Other sources of DNA, RNA may have cross-reactive genetic material that can be amplified by the RT-PCR test. False positives were observed unexpectedly in norovirus assays in patients with enterocoralitis due to usually high levels of human DNA in samples. 2. Contamination during sampling. This may happen if the swab head accidentally contacts or is placed on a contaminated surface. Example, gloves, hospital surface. 3. Contamination during swab extraction. Viral RNA is extracted from swabs in solution. Accidental aerosolization of liquid can cause cross-contamination between samples. 4. Contamination with PCR amplicon. The PCR amplification process generates millions of copies of the DNA target amplicon that can cause false positives in subsequent PCR reaction. If a testing lab is accidentally contaminated with amplicon, it can lead to sporadic false positives. 5. Contamination of PCR laboratory consumables. Contamination can spread from a post-PCR lab into a pre-PCR lab by transfer of equipment, chemicals, people, or aerosol. Even experienced national labs can be affected. In early March 2021, RT-PCR always produced by the CDC were withdrawn after many showed false positives due to contaminated reagents. So these are 5 case scenarios where you can get false positive. So don't keep thinking PCR in its interpretation or in its contamination can become false positive. You must be aware of that. So I think that should be enough. Maybe I will read off slide number 14. This is from Center for Evidence-Based Medicine, Norway. Please go there and have a look. cebm.net, www.cebm.net. Excellent website to be in touch with. A PCR test might find the virus it was looking for. This results in a PCR positive. But a crucial question remains, is this virus active, infectious or virulent? The PCR alone cannot answer this question. The CBM explains why culture in the virus is needed to answer this question. In viral culture, viruses are injected in the laboratory cell lines to see if they cause cell damage and death, thus releasing a whole set of new viruses that can go on to infect other cells. Without this proof, PCR positive does not prove clinical infection. You have to know that. So thank you for listening. There is quite a technical clip. Please send it to whoever professionals you know, and for people who are very anxious about track and tracing, random PCR testing, which is the war cry slogan of pandemic development. You have to put fear into people and get so many PCRs positive and shout loud about it as if it is clinical infection. It is not. It is just a dead particle that will not multiply in anybody. What is most important is clinical history and first level contact, not even far away contact. One person gets infected in a block of flats in apartment number 1, in level number 1, and then find PCR positive in level number 10 and say he's also a contact is completely unscientific. This drives the quarantine, this drives the phobia, this drives the threat and intimidation, and this drives the pandemic and the cry for a vaccine that is too rapidly tested without adequate testing. You know that Moderna and Pfizer vaccines were tested only on 5 people actually, though they are reporting 95% effectivity. This should not be. Let the proper vaccine come in time. At the same time, we know there's effective treatment. Hydroxychloroquine, vitamin D and zinc can effectively stop hospital admissions. In India, according to the Indian Council of Medical Research, they give home packs of hydroxychloroquine, vitamin D and C. They even give low-dose aspirin and omeprazole to prevent clot formation and reduce hospital admission, reduce risk and fatality. That's the way to go. Thank you for listening.